Everyone. My name is Daniel Gromer, and I'd like to thank the organizers of this conference for having us to discuss our work. I'll be presenting for the group you see below, and the topic I'll be presenting is the relationship between immunogenicity and reactogenicity of seasonal inactivated influenza vaccine using different delivery methods. I have no disclosures. The beginning of this study was a question, which is, does reactogenicity relate to immunogenicity? Or sort of more colloquially put, did my strong COVID vax reaction give me better immunity? And I wanted to pause for a second to ask, how many times did you think about this in the last 5 years? And how many times did your insert loved one ask you about this in the last 5 years? For me, I know it was a lot. What could you do with this information if you had the answer? If you knew that a certain vaccine reaction correlated well with a certain amount of vaccine-related immunity, you could impact vaccine distribution and implementation during a future pandemic. You could alter public health messaging about vaccine-related symptoms. You could research demographic disparities, study whether and how antipyretics affect vaccine responses, and inform future adjuvant dosing decisions in vaccine design. Very little was known about this topic by 2020. It was known that post-vaccination fever may herald increased immunity, prophylactic antipyretic analgesics may blunt immunity, and there was some interaction between adverse events, baseline immunity, and post-vaccination immunity with some early live attenuated vaccines, like the measles-containing vaccines. Since 2020, we've learned a lot, particularly about SARS-CoV-2 vaccines. We've learned that post-vaccination reactions are associated with increased immunity. And this has been shown with specific reactions such as fever and composite scores of reactions like the one that we will be using in this study. We learned that there's a stronger relationship, at least with COVID-19 vaccines, after the second boost vaccine in infection-naive vaccinees and participants. And this relationship is modified by age, sex, prior antigen exposure, and vaccine platform. There are a few terms I'm going to be using in this talk to describe vaccine effects that I would like to lay out here. One is reactogenicity, which I'll use to refer to typical inflammatory post-vaccination adverse events. There's local reactogenicity, such as arm pain, redness, and swelling, and systemic reactogenicity, such as headache, fatigue, and fever. There's also immunogenicity, which I'll use to refer to markers of post-vaccination immunity, in this study antibody titers, but also in many studies cellular assays. The readout of influenza vaccine immunogenicity that we'll be using in this study is a standard one called hemagglutination inhibition, or HAI titers, which are represented as a dilution log transformed for modeling and output as geometric mean titers, or GMTs, and for some hypothesis tests at least, as geometric mean titer ratios, or GMRs. A brief primer on seasonal influenza strains and antigens. Influenza A H1N1. The 2009 pandemic antigen was included in the seasonal influenza vaccines starting in 2010. And by 2014 to 2015, when the data from our study was collected, H1N1 represented a minority of circulating virus and had a relatively stable antigen. In contrast, influenza A H3N2, which is usually dominant or co-dominant as a circulating strain and causes most adult hospitalizations and deaths, at least in the United States, and has the highest antigenic drift rate, um, uh, was mismatched to the vaccine antigen in the 2014 and 2015 season. Influenza B has or had two distinct co-circulating strains, and trivalent influenza vaccines, or TIVs, were transitioned to quadrivalent influenza vaccines, or QIVs, during the 2010s gradually to decrease mismatch issues. Multiple factors are known to affect influenza vaccine responses. In terms of recipient characteristics, these include age, sex assigned at birth, prior influenza vaccination, and maybe body mass index. Other characteristics that matter and impact vaccine responses for flu include the vaccine delivery method. So the most common vaccine delivery method is intramuscular injection, which we'll refer to as IM for the rest of the talk. But a newer method is with a microneedle patch, or MNP. You can see how it works on the right in this slide. It's a small patch with very, very, very small needles, microneedles that inject antigen intradermally. This has been shown to have equal or better immunogenicity um, when compared to intramuscular vaccination, and has its own landscape of reactogenicity with a lot of redness, swelling, and itching as local inflammatory reactions. So our primary objective with the study that I'll be presenting now is to assess the relationship between reactogenicity and immunogenicity of inactivated influenza vaccine. Our primary method and aim was to perform a secondary analysis of a phase 1 trial comparing microneedle patch MNP and intramuscular IM delivery methods. And we estimated the effect of reactogenicity on immunogenicity, adjusting for measured confounding variables and stratifying by vaccine delivery method. To do this, we analyzed data from the TIV MNP 2015 trial, which was a randomized, placebo-controlled, partly blinded phase 1 study conducted at the Hope Clinic of the Emory Vaccine Center in the summer of 2015. Participants were aged 18 to 49, healthy, not pregnant, and immunocompetent. And here is the flow diagram for how data was utilized in this study. 100 participants were randomized, and we included the boxes in green. From the right, 25 who were assigned to intramuscular inactivated influenza vaccine were included in the analysis. And on the left, 50 who were assigned to microneedle patch inactivated influenza vaccine were included in the analysis in the MNP group. Our chosen primary exposure was reactogenicity broadly. The data for this was collected with symptom diaries for 7 days, and how we expressed this was summing tallied yes, no, 1, 0 reactions per participant. As an example, here is a made-up participant, participant 0 on the right. The reaction types are split up as local and systemic, and all the reactions are laid out before you. And in the gray grade column is the maximum grade of each reaction that this participant experienced. And summed at the bottom, there's a global, local, and systemic total. What we are using as a reaction score in this study is the tally column in green to the right, where everything is made into a 1 or a 0, and then the sums are what we use as our scores in the bottom right: global 5, local 4, and systemic total 1. So when generating these three separate scores, we dichotomized them um, in this way, and I used these little emojis to as a reminder: global, systemic, and local. And we positioned as our primary outcome immunogenicity broadly, for which, again, we used HAI, or hemagglutination inhibition titers. We had antibody titers against each of three influenza antigens in this trivalent vaccine: H1N1, H3N2, and 1B antigen. These were expressed separately by antigen as GMTs on days 0, 28, and 180. Secondary outcomes for immunogenicity included fold change, which is post divided by pre-vaccine HAI titer, and seroprotection and seroconversion, which are defined here and we're going to touch on much less. Other measured variables included BMI, sex, race, ethnicity, prior inactivated influenza vaccine in the past 2 years, and vaccine delivery method. Our primary statistical analytic method was mixed model ANOVA, which makes use of repeated outcome measurements and generates a longitudinal estimate and then split estimates by day. The output is geometric mean titer ratios that are estimated between group ratios at a single time point. and the null hypothesis is that an estimated GMR equals 1. Our secondary statistical analyses were a similar method, except for categorical outcomes, the modified Poisson generalized estimating equations, and everything else is sort of analogous. So to move on to table 1, these were the baseline participant characteristics, which were well balanced between the IM and MNP groups. I'd like to direct your attention to this bottom red outline box of baseline HAI titer to point out that H1N1 baseline titers were 1 to 80 in each group, and the H3N2 and B titers were 1 to 40 or 1 to 20 in each group. This is a correlation plot of the different reactions. You'll see nausea in the top left, for example, and pruritus in the very bottom right. And the takeaway from this visual is that there was not significant clustering between groups of reactions, such as like myalgia and sweating, to any particularly important degree. Now I'll walk you through an example table that we're going to be viewing similar ones for the next few slides. These are longitudinal associations between reaction score and HAI GMT. So we'll take a reaction type on the left. This one is global, then split by stratified by antigen and study group. And each one of these will output an adjusted geometric mean titer ratio, or GMR, as a longitudinal estimate, which has a little bit harder to interpret meaning, but maximizes power as sort of a screening way to detect associations. So for this table, for example, there's no statistically significant association, and therefore we don't sort of like split up, expand by study day. In contrast, the systemic and local group reaction types both had statistically significant findings with the H3N2 antigen and the intramuscular study group. And so we chose to drill down specifically on this antigen and this group for further study. In this table, we've depicted just the H3N2 antigen and intramuscular study group for the systemic and local scores, and expanded by study day. So you'll see columns day 0, day 28, and day 180 adjusted geometric mean titer ratio. And the statistically significant longitudinal associations are being driven by day 0 adjusted geometric mean titer ratios. So the way to read this on the top row, for example, is that participants with a systemic reaction score of 3 or greater had 0.4 times the geometric mean titer at baseline compared to those with a systemic reaction score of 2 or fewer. We also found a reasonably consistent finding in terms of titer fold change, that people with a higher reaction score, in this case, global reaction score, had a higher adjusted fold change in terms of their titers at day 28. Meaning that people with more reactions had their titers essentially multiplied by double, a factor of 2 compared to those with a lower reaction score. These findings were robust to one of a few types of sensitivity analyses that we did, and I'm happy to talk about these more. And I wanted, before we close, to touch on some limitations. We defined reactogenicity variables with an a priori approach that assumes that each reaction deserves the same weight. We used numerous model outputs, which made them somewhat difficult to prioritize, and we had a small sample size with a large number of variables, which made preserving statistical power difficult. On the flip side, in terms of strengths, our primary reactogenicity definition was generalizable, interpretable, and can be implemented in a clinical or clinical research setting. It's supported by multiple publications from the SARS-CoV-2 literature, and our findings were robust to at least some sensitivity analyses. Overall, this was a screening experiment using some advanced biostatistical methods to identify signals for future investigation. The main takeaways are that heightened reactogenicity to intramuscular inactivated influenza vaccine was related to low baseline humoral immunity against an included antigen. Participants with greater reactogenicity developed greater titer fold change after 4 weeks, though the response magnitude was actually similar or lower compared with low reactogenicity participants. I think the broader takeaways are that seasonal influenza vaccine immunogenicity and reactogenicity may be related in a different way than for SARS-CoV-2 vaccines. We used a trial of a new patch method of vaccination as an opportunity to learn about this relationship, and understanding this relationship will push the field toward more personalized vaccinology. Thank you. I want to thank you all for listening, and again, thank the organizers for inviting us. And I'm happy to take any questions and feedback that you may have. Thanks.